Several years ago, I visited different people's offices, and I would see an interesting patient, and I would wonder what was going on, how things really got to where they were. So I would ask for head films so that I could monitor that person's patient. And I'd say, where are the x-rays? Oh, they're around someplace. Well, can I see them? Oh, they're buried someplace. The truth of the matter was they didn't take progress head films, and many did not take x-rays after treatment. The result was that they never knew really what they did with their particular technique. Now, if we investigate the reasons why they didn't take x-rays, it was because they didn't know how to use them. Very simply, they couldn't tell the difference between natural growth and the effects of treatment. So in 1975, I believe it was, I wrote this article on a 4-step method to distinguish the differences between growth and treatment. We started with a central position, which was near the polar center. We wanted to know what to expect in the position of the chin and how much growth took place in the mandible. Second thing we wanted to know was the orthopedics in the maxilla. The third thing we'd want to know would be either the lower or the upper teeth, and since we're superimposing in position 2, it was easy to drop down and assess the upper arch first. So then we went down to the lower arch, and because the lower border resorbs, we could no longer accept the mandibular plane to evaluate growth or the effects of treatment. So this made it rather difficult to draw some hard conclusions without having another line of reference other than the mandibular plane. Now let's look at this one that we looked at yesterday, which represents 73 untreated patients, and this is natural growth without treatment. These are composites, which represent means, to be sure. Now, if you'll notice here in position 1, which this is, we did witness a 2-degree closure of the facial axis, and so we can see the behavior of the chin, as I talked about yesterday, and the carriage forward of the lower denture with that growth. And you can see here from 6 to 16 represents, wait a minute, I'm trying to get this in focus. This is what I'm trying to show now. This is 6 years and 64 hundredths to 16 years, so that's 9.64 years. And like we have talked about, there's very little change in the angle basion-nasion-A, and that's the picture of normal growth of the nose. My guess is that Orientals don't have a lot of difference in the amount of growth they get in their nose, but Oriental children start with a very small nose. They're cute. But based on the forecasts that I've made on Orientals, when I give the same amount that we use, it works out pretty well. It just starts smaller, but the gradient is about the same as far as I can see. Just as we had seen before, the upper teeth migrate forward in development naturally. Logic tells me that one of the factors here is the forward growth of the mandible. We use the word compensation, as I explained to you. Compensation, the word compensations means that something making up for something else. So with the forward growth of the chin, the upper teeth, by migrating forward, make up for that forward growth of the chin to keep the teeth in occlusion. Now, as this is done, you can see that the occlusal plane tends to rise evenly. So the angle between the occlusal plane and the corpus axis tends to be pretty regular. Now, from this position also, we can see the soft tissue of the chin. Now, here's a second group of children who were normal. They started out here at 60 and went down to 58. We've known for a long time that a forward growth of the chin and a good facial axis is favorable to the development of normal occlusion. The sample was dominated by males, almost 2 to 1, and we're looking at 10 and a third years between the two x-rays. So in that length of time we should see about 25 millimeters of growth on the chin. And it's exactly 25. So that pretty well confirms what we've been saying for the last 20 years. But the closure of the facial axis is a little bit more than what our previous ideas were. And we notice that the A point comes forward just a tiny bit. So with the forward growth of the mandible, it looks as though the whole thing has been invited to come forward just a tiny bit. But just as we found in the other sample, the upper denture migrates forward on the maxillary base. Now, in these normals, look how the lower incisor then moves upward and backward. And if we calculate where the third molar would be, you notice that it's halfway behind the external oblique ridge. So based on these averages, we should have, in the white population, about a 50% chance of having third molars come in. This tells me that third molars are taken out when they shouldn't be. In some patients. What is the incidence or the frequency of third molars reaching full function in the Oriental population? Very few, huh? Less than 10%. When I sent the survey to the Foundation for Orthodontic Research in 1987, the frequency was 18%. Yeah, in the natural population. That was a value judgment, and that was the mean of the value judgments of 150 orthodontists. Now we have some data here in these present studies that shows that extraction makes more space for the third molar. 1 millimeter represents about 10%, since that molar is about 10 millimeters wide. Now the next thing then is to see how the mandible is really growing, and in order to do that we superimpose on PM and on the anterior border of the ramus rather than the lower border of the ramus. We now use PM and the anterior border of the ramus. That comes very close to simulating the archeal growth of the mandible normally. Now you see what the lower denture is truly doing to true bone. And you notice how the lower arch moves upward and forward. As the mandible grows on an arc, there's progressively more space for the third molar. Here's a different group of patients. These were all class 2s, all treated with cervical traction. If you notice, the oral gnomon is 45, facial height is 59, and the facial axis is 89, which is remarkably similar to practically all the samples of class 2 that I have had sent in. Okay, now here is the behavior then in this group 8 years later, 8 and a third years later. Now if you notice the facial axis closing there too. If you notice, the face was good to start with down here, and the lower incisor was inclined backward because it was just erupting. It was posterior to its normal position, and the convexity was very high, 6.5 millimeters. Now, when we get through, we've got it reduced down to 1.7 millimeters. Now, if we go back to our data that I gave you yesterday, what is the rate of growth reduction of convexity? 0.7 millimeters every 3 years. So we could expect naturally an improvement of 2 millimeters of convexity reduction with growth. But how many did we get? Almost 5. So 3 of that can't be accounted for with natural growth. So there's something that's happened here. Now in 8 years, how much growth would we expect? What's 8 times 2.5? We'd expect 20 millimeters, and it's 20 millimeters. Now if you notice here, point A has gone back. Look at it. Internasal spine has gone back. Now this is long range. These people, this is dominated by females. There's 15 females and 4 males. So you notice the nose is almost touching up there, even after 10 years. So there was something going on here that is permanent. Now here is position 3, and even after 10 years you will see that the upper incisor has moved backward. Just for comparison, we'll show you here again what it did without treatment in normal growth. And these are class 2 cases that would probably have the upper arch going forward even more. So here is the behavior without treatment. And here is the behavior with treatment, both in the upper molar. Alright, now we will look in the lower arch. A lot of people say that in class 2 treatment, anytime you use intermaxillary elastics, you move the lower denture forward. See if you can see any difference in this and natural growth in the lower arch. This had a lot of males. This had a lot of females. So the growth here is going to be more than it was. Right? Now here's the archeal growth of the mandible. I should put the second and third molar in here. We can predict here, for instance, just let me do it for you, right here. Right here. Here is what I would forecast. Just like I would forecast, this is what would come out. This is about 11 millimeters wide. So we would do something like this. To predict where a second molar would be. Now, because this is only here now, you've got 3/4 of the tooth behind, so there's only a 25% or 20% likelihood that this third molar would erupt. So this would mean that that third molar is going to be impacted. At the age of 8.5, there's a hole there in the x-ray. It's the germ of a tooth. Now, it looks like it's down in the bone, but it's sitting on the surface of the bone. So we can go in there and make an incision right in the retromolar trigone, take a periosteal elevator and raise up and pop right in there with a spoon excavator. Now I'm going to do one for you if they have one to do over in Pacific Palisades. I've done many of them myself, and then I trained the local surgeons to do them. So I developed my own technique for it. Now, nobody would ever have an impaction if you do this early. So the patient goes ahead and grows as if it were congenitally missing. Now, the best part is that frees up the development of the second molar, and because sometimes when we treat with the utility arch, we will impact the second molar. I've never seen a second molar impaction in a case that I nucleated the third molar early. You see, the practice of most surgeons is that they feel that a big incision will heal at the same rate that a small incision will. In the training of most surgeons, it's amazing how big incisions they'll make. I make an incision no bigger than that. It shouldn't be over a centimeter. In Europe, particularly, it's known as germectomy.
Where?
In Europe.
In Europe. ヨーロッパではジャーメクトミーと普通
In the United States, years ago, we enucleated bicuspids and so forth, so we got the name enucleation over in the United States. I like germectomy better, so let's use that. Here's, don't forget this chart
この
that
チ
you
ャ
have
ートを
available.
このぜひ使ってください、忘れずに。
The facial axis, oral gnomon,
フェイシャルアクシス、オーラルノーモン、
BA and A,
BA
essentially don't change.
は基本的には変わりません。これ265ページ以降だと思います。
Facial angle, the mandibular plane, and convexity do change according to age.
フェイシャル
Now the frontal has been a no man's land for a long time. I kept working and working and working with it.
で、私は
And the breakthrough was when we started getting away from the gonial angle. The gonial angle is out of the plane of the denture. It has apposition in males, and it wasn't very fruitful to work out.
で、これが
The other part was finding a place on the maxilla to register. We didn't know where to measure to call it basal bone, and what was alveolar process. So we took the zygoma,
そこでこの胸骨を用いて
the zygomatic arch,
胸骨
the,
球
the outline of the key ridge,
このキーリッジのアウトラインを使いました。
and wherever that crossed over the outline of the tuberosity, pick up a skull. I want to make sure you understand this. We want to place on this curve someplace because that's bone that stays,
この
because that's carrying the stresses up through here. Usually when you take an x-ray, the tuberosity, which is back here,
で普通エクセンス取るときはこの結節部ですけども、
will show you a little line there.
このところでこのラインが出てきます。
So where this crosses over
で
that,
これとこれが交わるところ、
right there,
ここ
just
のところ
about,
大体こ
is
の
what we use as point jugale.
して使います。
Jugale, J-U-G-A-L-E.
ジュガリ点です。
Jugale. So that's going to be what we use as a representation of maxillary width. So let me see if I can tell you now how I use the frontal head. Cut through all of the garbage.
もういらないところは全部枝葉は省きます。
Get rid of all the confusion.
で、今まで混乱してたのを全部なくしたいと思います。
Here it is. Number one, I suppose, is asymmetry. You're interested in picking up asymmetries early,
評価したいわけです。
before
見つ
they
けたいわけ
become
です。
fixed.
これ
So in asymmetries in young children, you want to pick it up, particularly in developing mandibular asymmetry, because you will have functional crossbites.
なぜならば、
If the upper arch is narrow a little bit,
でもう
the mandible will be deflected
科学は歪んでしまいます。
one way or the other to get the teeth together. In fact, I've seen children that came in with a crossbite at one appointment, and the next appointment it was a crossbite on the other side.
こんなこと
I wrote an article in '65 called The Respiratory Obstruction Syndrome, where I talked about this very thing.
この
Number two,
今のが1点目でした。次2番目。
width of the nasal cavity. It's very narrow,
これが非常
and
に
if it's short, like you see in the lateral when it's up too high,
狭く
that needs your orthopedic attention.
この
Number three is maxillary width.
でさ
Can we widen the arch laterally? Number four is mandibular width.
4番
The next is the width of the lower molars relative to the width of the mandible and to the maxilla. So we relate the lower molar to the JAG line. Now there is very, very valuable use of the frontal head film with regard to the teeth.
この歯に関連して歯牙に関連してですが
I can do a better job of diagnosing potential canine impactions
で果たして
with the use of a frontal head film than I can with any other x-ray.
他の
So if you're going to prevent canine impactions, it's a good tool to have.
従って
You can also see all of the rest of the teeth and see whether or not there's any ectopic positioning of teeth.
もうお分かります
That includes every tooth. Last thing then is that we do have a facial mandibular index,
それからも
which gives us the capacity then to type the face in the frontal film.
でこれ
And we have some factors that we can use in the divine proportion to get proportionality in the parts of the face in the frontal.
で
After all, when I sit and speak to you, I'm not looking at your profile. I'm looking at you from the front.
なんと言っても最後に一番これがもうこれが一番いい理由だと思うんですけども。
Orthodontists treat from the side, but I'm looking at all your faces from the front.
でも今皆
And that's really what the business is.
我々の生涯はそういうことだと思
Of
う
a。beautiful smile, you don't smile from the side, you smile from the front. You don't look at your girlfriend and say, God, you're beautiful. Some years ago, I had a patient who was a model, and she'd gone in and tried to get a job modeling,
で
and the agent has a pretty good eye.
でこの
A good, successful model is set for life,
でも
particularly if she gets something on television.
う特に
Came in to me, and she had been treated by an orthodontist, and it was an admirable result.
で
In the profile, she did look very nice.
横顔は非常に綺麗でした。
But when she smiled in front of the camera, she showed the insides of her cheeks because her arch was so narrowed.
で非常に
So she comes into me now with a good occlusion.
でまあ
Everything in the lateral perspective looked fine.
ラテラルから見た限りすべて良好。
But here she is now with a naked smile.
ところ
So you see these graduations.
ね、
And isn't a great, natural, beautiful, normal occlusion? Doesn't that do something to you when you see a patient smile? The patient has a missing tooth in the front.
例えば前肢部で欠損部があると。
Something's not right. Missing lower incisor even. Something looks missing.
え
Take out an upper canine and let the midline go off and let it
それから
flop in. Something missing.
うまく
A
組み合わ
very
せることが
prominent American has an upper canine on the left side missing. Who do you think it is?
誰でしょうかこれ。
Ronald Reagan. A very popular movie star had a central incisor knocked out as a child. He was very
隠してしまいま
embarrassed,
した。
and it changed his personality.
でまた
He became a classic winter type and was a very popular movie star.
だけど
What was his name?
誰ですか。
Gary Grant.
経理
What do you think of when you think of Jack Kennedy?
それ
Teeth.
彼の歯。歯
How
が
about Carter?
からカーター大統領のその歯並び。
Teeth. Teeth.
もうなんていうか口中歯だらけというのかな、歯が目立つという意味で今おっしゃってるんですけ
Looks
ど、
like he had 4 central incisors.